What about lamotrigine? So lamotrigine, perhaps because of the problem with titration, may be one of the reasons why it's not surprisingly not that efficacious in the first few weeks. So when you see a patient with bipolar depression, and you think that lamotrigine is a good option long term, do you start the lamotrigine right away, and along with some concomitant, or do you wait until the bipolar depression is over and then think about the maintenance phase?
So that's an excellent question, is when do you introduce lamotrigine? The way the FDA studies were done, for a variety of reasons that have to do with the primary outcome measures and the baseline characteristics and the inclusion of bipolar 1s and bipolar 2s and the placebo effects, which were unusually high in the 5 studies that were done, the criteria for FDA registration were not met. So it did not get its approval as a monotherapy in acute bipolar depression. Even though those of us who were involved in the study, many of us believe that there's antidepressant efficacy for this drug.
Even in the acute phase, yeah?
I think the lamotrigine studies collectively were really a lesson in methodology. If you control for baseline severity, the separation from placebo was higher, and if you look at the outcomes in the 5 studies that were published, collectively, the placebo effects were awfully high. You will drive down placebo response by imposing a higher level of baseline severity. Doesn't mean that the drug works better in severely ill patients. It means placebo works less well.
It's the same as antidepressant clinical trials.
Exactly so. I think lamotrigine has a few characteristics that make it worth noting. So let's see. One is it is a very combinable agent that's pharmacologically non-redundant with many other things. So that is one factor. What's pharmacodynamically compatible? Lamotrigine with just about anything, even divalproex, as long as you adjust the dose accordingly.
Yeah.
There's the data with lamotrigine combined with lithium that has value in acute bipolar depression, the Vanderloos studies. I think that's often widely used. To the extent that lamotrigine may have an anti-cycling or an anti-recurrence effect, I think it pairs well with a lot of other agents in the acute phase. So personally, I often will combine lamotrigine not just with lithium, but with lurasidone or with olanzapine fluoxetine combination or quetiapine if one was using those agents. Lamotrigine may have particular value in the setting of mood instability. There's some nice data out of McLean from Mary Zanarini's group, borderline personality disorder, looking at affective instability. And we actually published a paper in Rapid Cycling with lamotrigine using life charting in bipolars, showing that they'll reach euthymia about twice as often week to week to week with lamotrigine than with placebo. So I think of it as a useful anti-cycling agent that has some antidepressant value, that is a very simple enough adjunct. And all the concerns that we had about rash in the beginning when the drug came out are important, but they're not nearly as pervasive as I think were originally thought.
Terrific. So you're saying that lamotrigine should seriously be considered even in the acute phase, but you may consider combining it with another agent, both because it may take longer to work and also because it may be synergistic with various other agents.
That's how I think of it.
But you wouldn't wait until the episode is over. You would start it from an early.
Yeah, I think while its FDA indication is for maintenance prevention, that doesn't negate the potential value of introducing it at any point in the illness, and to the extent that it can deliver some synergy to other agents and may even have some inherent antidepressant value by itself, no, I wouldn't delay in starting it.
So